皆さんこんばんは。今日は定例の勉強会なんですけれども、ちょっといつもと違って、金曜日じゃなくて、木曜日でお届けさせていただいてます。今週の月曜日からシエラレオネから研修員の方がいらしてて、看護師8名、それから、医療機器のエンジニアの方が1名で、医療機器の委員会の委員長をされている薬剤師の方が1名の計10名の方が研修に来られています。でせっかくの機会なので、実際あまり日本ではもうほとんど見ることがない、今回のトピックとしては新生児の破傷風っていうところをトピックに選んでくださって、そのことに関して今、実際にどういうふうな状況なのか、どんな治療がされているのか、どんなケアがされているのかっていうことを含めてお話ししていただこうというふうに思います。Thank you very much. From this Monday, we have 10 trainees from Sierra Leone, 8 nurses, 1 medical equipment engineer, 1 is a pharmacist, but he is also the chairman of the medical equipment committee. So this is a very good opportunity to know the situation in Sierra Leone. So today's topic is neonatal tetanus. So it is quite rare in Japan, and so we can know how they take care of the children and how about the treatment. So these kind of things we can know. So today's presenter is the Mr. James Koroma, and he is a matron. Matron means our Deputy Director of Nursing Department. So he is the president.
Thank you.
Yeah.
Good evening, JICA. Good evening, ladies and gentlemen, and members of the International Medical Relief Committee. I actually realize the work you do. It is both an opportunity and a privilege for me to be here with you today. And I realize the work you do in responding to medical emergencies all over the world. Today, I am going to present the most critical topic, neonatal tetanus, which is it's actually preventable, but yet it's deadly in vulnerable countries. Neonatal tetanus, of course, it remains the cause of death in developing countries like ours, despite the fact that in developed countries, it is actually rare. This case that I'm going to present today was managed at the Oladiri Children's Hospital by our nurses and, of course, a volunteer from US who came to actually help us in neonatal affairs. Awareness of the diagnosis and management is necessary when we have home deliveries in our country. Now, of note that we also note that recovery does not actually afford future immunity. It does not mean that when the baby recovers, the baby might not have tetanus again. Now, let me briefly talk about tetanus. Tetanus is a condition or a disease that is caused by a bacteria called Clostridium tetani. Now, this bacteria is found on the soil. And when it enters through contaminated wounds, mainly affected on babies that are not immunized. Now, also, the other main cause is poor deliveries and dirty deliveries, according to the World Health Organization. It is preventable if we actually immunize the children and we perform clean deliveries. Vaccinating women actually protects both the mother and the babies. According to WHO's recommendation, the tetanus containing vaccine doses must be received 3 in infancy and a booster at age 12 to 23 months, 4 to 7 years, and 9 to 15 years. Now, briefly, the tetanus is caused by a bacteria, as I was saying. Now, this bacteria has some properties. It is a gram-positive. It is anaerobic, that it cannot survive where there is oxygen, and it's a rod shape. As you can see the shape there, when it is without a spore, it is rod, and when it has a spore, it's like the shape of the tennis racket. That is why it's called tetany. Now, if you look at the spore, it has a core which contains DNA and enzymes, and it has the cortex that actually protects it, and it has the germ cells. When it germinates, it helps to germinate. Then the coat actually protects it, that makes it resistance. So when this, of course, the tetanus produces poison called tetanospamine, which actually interacts with the central nervous system, which makes it, which causes the tetany. Next slide. Now, most common, how does it enter the body? The most common portal of entry of this bacteria is the umbilicus. 90% of cases present at Oladilin, of course, from the 3 to 14 days of life. Well, we found out that correct management can reduce mortality by 50%. Now, usually, the onset of neonatal tetanus is 1 week. It ranges from 1 to 1 month. And the clinical symptoms you may see, the baby will not be able to suck. They may have fever, become rigid and spasm. They may have seizures. And of course, it causes spasm on the larynx, which is laryngospasm, and can lead to aspiration pneumonia, which is a common cause of death. And of course, the diagnosis is based mostly on clinical presentations. Now, as I said, it produces tetanospamine, a toxin. Now, this tetanospamine, now, when the tetanus bacteria enters the body, it travels through the blood and the lymphatic system to a distance onto the neurons, first affecting the muscles with shorter neural paths. So the toxin now binds irreversibly to inhibit the synapses that's between the nerves, blocking acetylcholine release. Now, this inhibition lowers the motor neurons, increases tone in both agonist and antagonist muscle, which leads to rigidity and spasm. Now, the toxin may also block neuromuscular transmission, which causes paralysis. Now, laryngospasm can cause in aspiration pneumonia, because if it causes the larynx, we are in the oxygen enters, of course, the baby will not be able to breathe. A common cause which kills the babies. Also, improvement usually is within 3 to 7 days. So if you are managing this baby, there is no improvement between 3 to 7 days, you start worrying. So you need to reduce the spasm, the episode, and improvement in the muscular rigidity. Now, resolution may take up to 45 days. Survivors often exhibit developmental disabilities. Now, the lasting effects of toxin may be reduced by the neuronal generation of additional branches and the creation of new links among the surviving neurons. If treatment is not given, it has a mortality rate of 90%, asphyxia, leading to asphyxia and, of course, hypersynaptic response and common fatal complications. But with ICU, with intensive care unit care, survival can exceed 50%. Of course, full recovery is possible, but some develop complications. A study in Kenya showed that 20 to 40% had permanent issues like brain damage, microcephaly, and neurodevelopmental problems. And another Nigerian study also states 20% those that suffered cerebral palsy and cognitive delays, and of course some become deaf. And this is a graph that shows world mortality incidence, and of course it shows that it is declining from 2000 onto 2022. It's actually declining, but it's still prevalent in developed countries. Now, for Sierra Leone, let's come to Sierra Leone, the country where I come from. The next slide will show how the current trend of neonatal tetanus in Sierra Leone. Next slide. So you can see the graph. It shows the trend. Of course, there are some changes. You see, because we are trying to eliminate the maternal and newborn child elimination of tetanus from 2000 to 2022, 320, and for those delivery that are done by skilled birth attendants, it's 134. For newborn, it's 86. And I think we are trying to have 0 cases, but it is still prevalent. Now, next slide. So this case I'm going to present is a 9-day-old baby that was delivered at home and brought to our facilities. Now, this 9-day female was delivered by spontaneous vertex delivery, but the mother was a teenager. The delivery took place at home by a traditional birth attendant. Now, the baby cried, according to the mother, immediately after birth, but home water and towels used to clean the baby's cord. She presented on day of life 9 to our facility, a 2-day history of fever, cough, unable to cry, refusal to be breastfed, able to suck. The baby was twitching with episodic spasm. Now, the baby's name, FK, was a female, of course. The mother, of course, the gestational age was 36 weeks and admitted at day of life 9. Now, mother's age was 18, as I was saying. Antenatal, this mother actually visited 2 antenatal clinics, which supposed to have visited more than 8 to 10. Now, and treated for malaria, preventive tetanus toxoid, was received only 1 TT when she was supposed to have received 2. So the weight of this baby on admission was 2.73 kg. Now the height was measured, which was 44 centimeters, and the head circumference was 36 centimeters. Now these are the clinical presentation. The baby was actually appearing to be ill. The baby was irritable, was not able to suck. The jaws were stiff, a condition called trismus, and generalized rigidity. But when we measured the saturation, it was 98% on oxygen. Now, the baby was not in respiratory distress at that particular time. Respiratory rate was 46 breaths per minute with bilateral equal breath sound. Now, axillary temperature was measured, it was 37.4 degrees Celsius, but was tachycardic with a heart rate of 190 breaths per minute. Beats per minute. Now, the heart sounds were normal. The first and second heart sound, no murmurs. No abnormality on the umbilical stump because it's already fallen. Abdomen was on normal fullness with tense abdominal muscles. The rectum had normal stools. Now, how do we manage? How do we diagnose? The working diagnosis, day 2. Based on the history, the mother only attended 1 ANC. The mother received only 1 TT. Physical examination, stiffness, trismus, and of course the progression of the condition made us to make the diagnosis of neonatal tetanus. However, there are differentials. It's called apart from neonatal tetanus, which we confirm, it can also be due to pseudotetanus, or it can be birth injuries as a result of intraventricular hemorrhage or intracranial hemorrhage. Or rabies can be hypokalemic tetany seizure, or meningitis, or encephalitis, or it could be due to dystonic reaction as a result of antipsychotic medication or central dopaminergic antagonists. These are all differentials we wanted to rule. Also, strychnine poisoning. Of course, for strychnine poisoning, it's not actually available, but it's a poisoning that that is acquired from the strychnos tree. It's all I haven't seen any in our country. I think those nuts are available in India and I think Southeast Asia. And of course, it can also be sepsis, seizure, inborn error of metabolism. Now, the treatment on admission, when the baby comes immediately, the baby was supported with oxygen by nasal cannula. And of course, because the abdomen was tense, it was on NPO, nothing by mouth. Nasogastric tube was inserted for feeding when appropriate. Then dextrose 10% saline at 11 drops per minute at 100 ml per kilogram per day was calculated and was given. And we also supported the baby with antibiotics according to our protocol: ceftriaxone, gentamicin, metronidazole, phenobarbital load, and diazepam. And of course, the nursing care, close observation per protocol, vital signs monitoring, suctioning when necessary, and the baby was nursed in a quiet, dark area with minimal handling to prevent further damage on the brain. Of course, then we actually notify the surveillance team because it's a communicable condition. Of course, this condition, you can see the work of breathing. Just click again. You can see baby was now in respiratory distress. You can see the tracheal tug moving, intercostal. Next slide. Okay, so the physicians actually ordered laboratory investigation. They ordered CBC to do complete blood count, blood and urine culture in order to be able to rule out sepsis, erythrocyte sedimentation rates. They actually ordered CSF, cerebrospinal fluid analysis, so that to rule out meningitis and other blood chemistry, random blood sugar. But because of lack of funding, it was only the WBC was done, which was abnormal, which was high, and random blood sugar were done. Now, tetany, of course, the baby was stiff, which was one of the baby actually. Next slide. Okay, so now this is a plan. These are the plan at our hospital for a patient like this. When the patient comes in, we try to neutralize the toxin using the human tetanus immunoglobulin. We also try to control the spasm using antispasmodic like diazepam and phenobarbital. Then we give the patient fluids according to this protocol. Next slide. Now, antibiotics therapy is also given in order to eradicate the pathogen. Now, for some of the antibiotics we use, metronidazole 15 milligrams per kg as a loading dose. And of course, after 24 hours, 7.5 milligrams per kg 12 hourly for a period of 1 week. And ampicillin 50 milligrams per kg BD if the baby is less than 7 days, or TDS 7 to 21 days, and QID greater than 21 days. And gentamicin 5 milligrams per kg if OD if the baby is less than or equal to 7 days, and 3 milligrams per kg if the baby is less than 2 kg, and 7.5 milligrams per kg if the baby is greater than 7 days. Now, of course, we also, because the baby has fever, we also give oral paracetamol in order to manage the fever. And of course, aseptic technique. We normally, if the umbilical cord was still intact, we clean the umbilical cord, we treat it with 7% of chlorhexidine. If not available, surgical spirit is done. Now WHO recommends that we manage it with open air. Cord infection, of course, may demand separate treatment if it was infected. Now, of course, we also provide foods and fluids, mostly breast milk. Good nutrition, of course, is vital, as muscle spasm consume a lot of energy, so the baby needs to be fed. Feeds should be frequent and small because of course, the spasm, the risk of hypoglycemia and aspiration. So that's why we must have frequent small feeds according to the child's age. Now, if very unstable, we keep the baby nil per hours and start IV feeds at 150 ml per kg per day, but change to feed as soon as possible. So this, of course, the protocol demands that we need to monitor. And of course, diazepam and phenobarbital cause respiratory depression. So we need close monitoring when we administer such drugs. And of course, we need to maintain a vital sign chart, blood glucose charts, cardiac monitoring charts, and spasm charts. So both spontaneous and provoked spasm must be monitored. And fluid intake and output also must be monitored, and laboratory tests, fluid balance charts, and of course, vaccination. So now, let's see what we did. Of course, as I said, we are in a low, medium income countries. This is a plan. When everything is available, we'll do everything for the baby. But let's see what was done for this baby. Now, this table actually shows what was the treatments and nursing care given, the outcome, and what was not done and why it was not done. Now, the respiratory system of the baby was stable. The saturation was mid-90 initially at when the baby was on oxygen by nasal cannula, but the baby was apneic. And saturation, okay, the baby became apneic and saturation drops on 80 or day 10. So what treatment was given? Oxygen was given, 100% oxygen given per minute by nasal cannula. And the outcome was there was initial stability, but it deteriorates by day 10. So now what was not done, this was not escalated. Now, because we don't have a ventilator, so we cannot escalate that. Let's switch to a ventilator due to lack of the equipment. Now, the cardiovascular system, the heart rate baseline is in 140. So it actually goes up from 190 to 200 with fever on day 12. So what was done? The vital signs were monitored closely. Oral paracetamol given at 10 milligrams per kg. Minimal handling was ensured. Baby was hydrated and antispasmodic given. But the outcome was that tachycardia, of course, correlated with fever. The higher the fever, the higher the pulse rates. Okay. But no cardiovascular collapse noted. Now, neonates not isolated, no separate room for isolation in that place, although it was separated from the other cots on a very small cot covered with cartoons, of improvised cartoons. Now, the GIT, the baby was actually nothing by mouth from the 1 to the 6. And we started NG feeds at the 8 and 9. So vital sign, NG tube feeding with express breast milk at 25 ml every 3 hours. IV fluids management was done. Nutritional assessment was done. And the outcome was that nutritional support resumed when we give express breast milk, and it was tolerated. But what was not done was that, of course, we should have checked electrolytes because the baby was being nil per hours. But electrolyte checks not done due to lack of funds and basic labs. And looking at the central nervous system, days 2 to 7, there was frequent spasm. Baby started having frequent spasm. So days 8 to 10, there was reduced spasm, and the 11 to 12, they became unconscious. So what action we are taking? Of course, we continue, okay, minimal handling, gentle suctioning, we covered in a separate course. Then in order to control the spasm, we administer diazepam 0.3 milligrams per kg 4 hourly, followed by continuous infusion because the spasm we are frequent at 0.1 milligram per hour. Then of course, we give phenobarbital loading dose, 20 milligrams, then followed by maintenance dose at 5 milligrams per kg. Then, of course, the baby was, the physician prescribed 10,000 international units of tetanus ATS and tetanus serum, but the baby only received 1,500. So there was initial improvement in spasms, but deterioration later with unconsciousness. So what was not done and why? The baby received only 1,500 units of ATS out of the 10,000 prescribed due to lack of funds. And there was no access to tetanus immunoglobulin. Now, infection, the fever increased from 37.4 degrees Celsius to 40 degrees Celsius by day 12. But no laboratory investigation done so that we can find out whether the baby was infected or not. Temperature checks, what do? We continue checking the temperature and record, and we give paracetamol at 10 milligrams per kg every 6 hours. The outcome was that the fever temporarily controlled, but it spiked again day 12. What was not done? No culture and sensitivity results due to lack of funds. This, the pharmacological management, as I've mentioned earlier, following protocols. IV, we gave metronidazole, 41 milligrams loading dose, and of course, on day 1, then after 24 hours, 20 milligrams, 12 hours for 1 week. Then we gave ampicillin, 50 milligrams per kg, which was 136.5 milligrams TDS. Injection gentamicin, which is available in our facility, 13.67 milligrams OD. And paracetamol in order to control the fever. We gave it by NGQ 6 hourly. Phenobarbital, the loading dose, followed by the maintenance dose. And to control the spasm as well, diazepam 0.8. Of course, the diazepam ranges from 0.8, the maximum to 0.9, the maximum is 0.8. You can give up to 0.8 if the respiratory rate is greater than 30 breaths per minute. And of course, we support the child with IV fluids. Now, but we tried terminally. What happened? The baby could not survive the complication. Next slide. Now, there were persistent seizures despite our efforts. Worsening tetany continued to worsen. The child eventually passed on day 12 of hospitalization at day of life 21. Now, what are the lessons learned from the story or from this case? The baby presented on day 9 with 2 days of progressive symptoms. Early recognition and referral of neonatal danger signs at the community level is important. If the baby would have come to us earlier, maybe a different story would have got a survival. Then the next thing again, the baby was delivered at home using unsterile tools and materials. Now, skilled birth attendants and clean delivery practices prevent infection like neonatal tetanus. As we saw earlier, the skilled birth attendant versus unskilled birth attendants. Now, another thing again we learned, only 1 dose of tetanus toxoid was received during pregnancy. The nursing implication, full antenatal immunization, at least 2 doses is important for neonatal protection. Home delivery due to distance from health facilities. Of course, we need to address the geographical logistic barriers by outreach or community health strategies. Then, of course, again, the family is unaware of home delivery, because if they are aware the dangers of home delivery, I don't think they will have delivered at home. Well, this enhanced community education. So we need to go on in community education on neonatal danger signs and facility-based care. This is very, very important. And the nursing care was provided minimal handling, feeding, monitoring, but the baby deteriorated. So that shows that early prevention is very key. Nursing care alone, management, drug therapy, supportive care cannot reverse advanced tetanus, because remember, the baby presented at 9 days of life. Now, action points. Here are some action points that we need to implement. We need to equip our nurses and community health workers with skill to identify neonatal tetanus symptoms and refer cases promptly. And we need to advocate so that our pregnant women will receive the tetanus toxoid at ANC. And home visits, but postnatal visits, so that we encourage the mother. We teach them how to identify danger signs so that they will not come to the clinic late. So when you see this danger sign, baby cannot soar, you see this fever, come to the clinic. And we need to educate caregivers during antenatal and postnatal care on hygienic cord care and signs of infections. So we need to go to antenatal clinics and the postnatal care units, teach the caregivers there. And of course, advocacy for improved maternal and newborn health services in medically underserved areas. Now, we also need to provide maternal health supports to those category families aiding recovery. That's the end of my presentation. Thank you for watching.
Thank you very much for the presentation. I'm sorry I didn't tell, but if you have any question and comment, please write in the chat box. And any question from the mute? Can I ask?
Yes.
And you were talking about the traditional birth attendant. And is it still very common in Sierra Leone? And also, if I know in the skill you have a TBAs, but also the government or from midwife, they provide any training to prevent this kind of the neonatal tetanus.
Yeah, it is still common in the country. Initially, they were providing training for them, but now the government is trying to discourage untrained, unskilled traditional birth attendants to carry out deliveries at home, because they are training more midwife. In fact, that is why you have the University of Sierra Leone College of Medicine and Health Sciences now has a faculty of nursing and midwifery, the midwifery components, apart from the midwifery schools we have in Freetown and the provinces. So we have a lot of midwives now in the country, but they are still practicing without the government knowing.
And thank you very much. And you also mentioned quite often happened aspiration pneumonia. So as a nurse, the nursing care, what kind of position is good for these kind of the tetanus patients? Because they have a spasm. So how do you do the positioning for this kind of baby?
And of course, if you see the picture on the baby, you see the position is a bit, the head is above the other part of the body. I can say the up the phallus position, I can call it, so that you prevent. And of course, you need to tilt the neck on the other side, so that you prevent the fluid rolling, because it can't be controlled. Once there are a lot of fluid and there is spasm of the larynx, it can easily go into the airway. So you need to position the baby a bit upright, and of course, on the left, turn the head on a bit. But since the baby is stiff, so basically it is upright position.
So sometimes you suction
the suction.
saliva
When you see, you suction only what you see, so that of course, one of the nursing management is to also avoid overstimulating the baby. So you need to be suctioning to remove the fluid.
Yes. I have a question.
Okay. Thank you very much, sir, Mr. James. I have one question. I'm looking at the community sensitization, or based on community services. Since you noticed that this baby was delivered on a home, was there any visits to this particular home so that you can be able to get good information from this birth attendants, or did you visit so that you can be able to educate this birth attendants on what was the result that you got out of this baby?
But that is the role. That's why we immediately reported to the surveillance team, which is their role. So my role was to actually report, and we reported to the surveillance team, and it was the role of the surveillance team with the social worker to do a home visit, and of course they visited.
Thank you.
Yes.
I just want to ask about admission of this people during the assessment. What's the state of the American?
Of course, it's already fallen. That's day 9. The baby was day 9 of 9-day-old baby. It falls within a week. But we say in confirmation of the, of course, tetanus is. You cannot do a blood test to confirm because the bacteria is not in the blood. So the diagnosis was based on the history and the symptoms.
Thank you very much.
Yes, Mr. Coleman. When is baby transferred? What was the advice that was given to the relatives, the mother and the relatives?
Of course, care of the baby family. The mother was counseled. Thank God there was the social worker was there, because I'm working directly with the social worker. I have the social worker office. The social worker actually came. They had a session, and I've got the nurses in the SCBU also had a session with because the mother was a teenager, but there are people surrounding the mother, so all of them were educated on the prevention of such subsequent fetal mortality by teaching the mother when they get pregnant, on the importance of attending antenatal clinics, and the importance of tetanus toxoid. Okay, so
is it okay? Thank you very much. Wait for a while. We also have one question from the audience. So, did you get any information from other JICA projects in other countries? Example, in Bangladesh, JICA has successful MCH project. So, did you get any information from other JICA projects?
In our country?
Or yourself, or
Okay, if during the studies, no, I did not get any information.
I hope I think if you have more information, we also have the maybe from the audience, maybe you can explain a little bit about the Bangladesh JICA project, MCH project, if possible, because this is also maybe interesting to help the situation in Sierra Leone.
Okay, I think I heard about the maternal handbook, which has been implemented in, of course, successful in Ghana, and it has also been, it has also started in our country. Yes.
So you heard the some MCH project in Ghana.
Yes. Yes.
Okay.
In Ghana.
Yeah. Yes.
Yes, I want to thank Mr. Kruma for the wonderful presentation. And I just have few questions for Mr. Kruma, maybe also the hospital where this case was presented, if he can answer both of them. So with regards to the case he presented, if you can observe keenly, yes, maybe somebody will think about the primary cause of the child death is the tetanus. But in another situation, if you look at all these resources available, we think that the primary cause of the child death is due to fall. Because from the presentation, most of the areas, medications were available, but there was lack of fund. So I want to know, since Mr. Kumar was interested in this child, what did he do, or what did his hospital do to save this child's life by providing the tetanus, the antitoxoid that was lacking during the treatment? Thank you very much.
So it means still it is very difficult to purchase. Still, it is very difficult to purchase because of quite a lot of the medicine for even immunoglobulin is lacking, right?
From the
Sierra Leone,
presentation.
yeah. But how about now? Still, we have the same situation in
But-
Sierra Leone.
But the child received 1,500, but due to the lack of funds, do not get the remaining.
Yeah, at that time.
Yeah.
But how about now? The situation is getting better.
It was available.
Is-
The antitoxin was available. It was the immunoglobulin that wasn't available.
Yes.
So what did he do, or what did his hospital do?
Yeah, so now let me answer your question. The doctor prescribed 10,000 international. They're supposed to have 7 vials, and they are selling 1 vial 250,000 bills or 200 bills in our currency. So the mother, that's one, even that one was supported by the physician.
It is not always
From his
Yeah,
pocket.
yes, from his pocket.
Yeah.
And it cannot continue with the rest.
Yes, I think the lack of fund was like, I think from the hospital level, if the medications is not available, they ask the relative to buy. And as he rightly said, the guy is a teenage, maybe, I don't know if there was a father, maybe to even responsible, or maybe the grandmother or so, or the mother. So in this case, I don't know if there's any facility, like if a drug is prescribed for under 5 that is not available, is there any organization or group that you need to meet and advocate so that they could step in and then support in saving the baby's life?
Okay, now, yes, if at that moment, of course, even my office is at Oladile, is the child mental health and psychosocial units. That's my office. And I have a show worker there. And of course, there is evidence of what we have been doing for children who have been abandoned, for children who do not have. So most of the time, for several occasions, my social worker can testify out of my pockets how many of them I have supported. But you cannot just be supporting and supporting and you give your pocket empty. But for critical cases, personally, and of course, you know, the physician is also has humanitarian feeling at that SCB. She has also been supported. And of course, apart from the physicians, even the staff nurses, and of course, you have well-body partners, and even the consultants, the project volunteer that we actually did this case study was also there to support, but by then it was too late.
Yes, Mr. Kumar.
Yeah.
Thank you very much. Yes, in the presentation, you mentioned about a ventilation, a ventilator. What was your what was the input in relation to management for the availability of this equipment for future occurrence?
Well, the equipment, I think they brought one. This is functional. But we don't have. Very good. So I'm saying what they been needed when you are in respiratory distress and you are going to respiratory failure. Take note. You have done your bag max, you fail, right? Let's say the last resort is to put the baby on ventilator, but it was not available. So therefore, you cannot provide what you don't have. I think that led to the death of the baby, respiratory failure, because there was, let's say there was a ventilator and the baby died on the ventilator, but it was not available. And we are still advocating. You are the head of the maintenance, the medical equipment, right? So help us to advocate so that we can have one ventilator. At least, when we visited Ghana, so they are picking, they say they have up to 6 ventilators. 6 ventilators. But we don't have. So our babies are dying.
Okay, yes. In relation to that, as you mentioned about my advocacy, and this thing, it will be an open opportunity and also to advocate on behalf of the government of Sierra Leone and the children of Sierra Leone that we are a key need of the ventilator equipment which can be and help to save life in terms of this type of cases for it not to be repeatedly occur in our country. So I'm keen appeal to donor partners, JICA and other healthcare providers to see how urgently they can help our country with this type of equipment from the medical equipment point of view. Thank you.
Thank you so much. And also in the chat box, and also from the audience, also there is some story, and also the part project in Bangladesh regarding the Titans.
Okay.
So this one you can also have a look,
Okay.
and what kind of things happened in Bangladesh. And one more question is, do you have any special educational materials for improving early detection of symptoms by family members? I think regarding Titans.
I think that's going to be the next step, because we don't have formal, although we do verbal teaching on the at ANC level, but we don't have a protocol, let's say education material. Maybe it's going to be our next step.
Okay. So it means some nurses or midwife explain to the pregnant woman, but some not. It's not some kind of.
Yes, some at ANC.
All right. And one more is also, thank you for your clear explanation and the case study on tetanus. I agree with your comment about the need for mental care for the families of deceased babies. If there is any care that you are currently providing for the families, I would like to know what you are doing.
Okay, at present. Now, in the wards, the nurses provide psychosocial support. We have a lot. The deaths are too many. It's not like in your country when you have 0.8 death per 1,000 life back. We have 32 per 1,000, 31 to 32. And of course, babies are dying per day. You can have 1 or 2 to 3 or more, or 1 or 2 per week, per day. And you, of course, you must provide psychosocial support. That one is done for every shift. If your shift, you have a mortality in your shift, you must provide psychosocial support. And not only that, even at PCMH or at the labor and delivery room, those with stillbirth, those who lost their pregnancies, you also provide what you call grieving support. But it's not financial, but that psychological support is provided for the family.
Thank you so much.
And of course, I'm interested on it, although the work is too much. We are at the hospital where this death occurred, already, of course, you know, we only have 1 social worker. And even at GMB, for now, we don't have 1. So we are trying to recruit 1 so that we can have a social worker. And of course, train to be providing psychological support.
Yes, sir. So in this kind of situation, don't you think that infection prevention and control is also necessary to be implemented, I mean, to the families, to relatives on how to take care of their babies?
Of course, that's what the education given. That's what of course, that's the mistake they did. Of course, because they were unaware. They did not aware that home delivery is dangerous. If they were aware that using contaminated material, maybe the TBA used a contaminated material to actually cut the cord. And when you see the story, water and towel was used to wrap the where that towel come from. And you know the Clostridium tetani lives on dirty soil. So the baby the family was educated on how to prevent this further or subsequently. Of course, infection prevention control plays a role. That was why we immediately summoned the surveillance team.
Thank you very much. So do you have any other questions from the board? No? Okay, thank you very much for your great presentation. And also we're very happy because so many questions, so we can know more the situation in your country, also how we have to do for the baby with tetanus. Thank you very much.
You're welcome.
Thank you.